Yeah. And Jill, did you do you know if Laura would be able to make it? I thought this might be good
She
for
is
Laura.
not going to be able to make it today. She is slammed with meetings, so I am representing us on the
Okay.
whole. Yeah.
All right, so you can relay anything interesting to her.
Oh, absolutely.
All right, so wait a couple minutes. But Jill, you've met Nirah before, right?
Yeah, we've met at a couple of meetings, I believe, and we were in D.C. together.
Oh,
Yes.
that's right.
Yeah, I was the passionate one in that one meeting because I had been on vacation. I was overtired, and still passionate.
Yes, I remember. That was great.
I heard Fabian is moving on.
She left. Yeah, she left in September, a while ago now. So
she was actually at the liver meeting presenting on, I guess, the Check Hep B or one of the Hep B programs.
Inspire, probably. Yeah, I didn't know that. So yeah, because that was.
I saw Eric. I haven't seen Eric in a long time.
Mm-hmm. Yeah, he's focusing on policy now. Did he mention that?
No, I didn't know that. And then I met the person who's acting, I guess, for now.
Ann Winters, yes, she's great, and she's been here for a long time and a lot of experience. So.
Oh, good.
Where was she? Great.
What was she in, hepatitis or somewhere else?
No, she was in the Bureau of Communicable Disease for a long time, I think 8 years. And then prior to that, she was in the Bureau of TB and various other health department programs. So it's a great fit. Yeah.
Yeah, so we had a poster there about our New Jersey Hep B program, and she had a lot of questions. So I was really happy to see that, she cared a lot about Hep B.
That's so great.
Yeah, it was really nice.
That's great. I did see some, Twitter and Facebook posts from the meeting. I was going to go, but then I had just gone to a conference recently.
Yeah, you went to the harm reduction one,
yeah,
right?
and I just felt like it's a lot of travel, and so many of our team was going. I just wanted to sit this one out.
Oh, yeah. So
How
who
was
else
it?
went besides Eric? It was great. It was, a ton of people.
Great. Yeah.
A lot of MVHR people.
Uh-huh. So there's a new member of our team, Tosin, who also is working on our Hepatitis C Clinical Exchange Network project. She was there, and Ryan Duerme, who's been working on that, and then Marie Bresnahan, who also works on Inspire. So there was like five team members there.
That's great that you guys were all able to go.
Yeah, yeah. I mean, obviously it's a really important meeting for our work, and so we haven't heard the debrief yet. Was there any good news about Hep B?
I mean, it was still mostly Hep C. Definitely, like the entire viral hepatitis debrief was on Hep C, but Anna did give a final talk on Hep B elimination. And probably one of the most packed talks that I saw was there was NVHR and a law, what is it called? It's a group at Harvard that does law, policy, and quality. So they released this report on state Medicaid coverage of Hep C drugs, and it was really well attended, and obviously caused there was a lot of attention to that. So, yeah, that report. Did you see it? It was like released on Monday, I think. Either Sunday or Monday. They released it with the meeting, so you guys should take a look at that.
Yeah, I haven't actually looked at it yet, so.
Yeah, it's long.
But I will.
It talks about like which states have become more restrictive and which states have been less restrictive on the coverage of the meds. So, Suda, are you there? I just saw a text from Suda saying, "Sue, can you hear me?" Suda, we don't hear you, although I do see that there's a microphone next to you, so you should be on. Let me have her call in. Did you call? It's Winchi. Hi, Winchi. So maybe we can do some brief introductions so Nirah can know who you guys are. And Nirah, maybe you can talk a little bit, about what your overall role is and how you got to where you are.
Okay.
For a little while. Yeah, and then we'll start off with that, and then we'll see who else calls in.
Okay. Me first or others first?
Why don't you start first, and then I'll have everybody go around.
Sure. My name is Nirah Johnson. I work in the New York City Department of Health. My background is in social work, but I've been in the health department now for exactly 9 years. My 9-year anniversary was November 12th. And I started out doing more community organizing, organizing our Hep C task force and Hep B coalitions, and doing training and outreach and education, and then doing some special projects around tools, clinical and non-clinical provider tools, like and communications tools like printed materials, apps, text campaigns. And then in the last few years, I've also taken on program implementation. So I manage our direct service patient navigation and peer navigation programs, which I'll discuss today. So these days I kind of have a wide variety of responsibilities and roles here in our program. And in our program at the health department, we have now about, I think, 27 viral hepatitis program staff. So we have policy staff, we have surveillance, my unit, which is the capacity building unit, and we have some grant units as well. So we're sort of a growing program, so I'm excited to share our resources.
Great. I can't believe it's 20-something people now.
I know.
It wasn't even its own little department when I left.
Yep, it's drastically expanded in the last few years. So.
Right.
Yeah.
All right, so why don't we go around, maybe my team can introduce themselves first, Ruth and Winchie.
Hi. Hi, this is Ruth. I am working with Dr. Sue Wong and Wenqi and Judy Yen here on the CDC Hepatitis B grant, and we are now going into year 3. We just started year 3 of our grant, which will end the end of September 2017, and we are looking to 600 patients to be screened hepatitis B here in in New Jersey, up from our 500 that we were able to do last year.
Oh, my turn? Okay. Hi, this is Winchie. I am the coordinator for the hepatitis B grant from CDC in Dr. Su Wang's office. So, you already introduced the whole grant. So my role is more like linkage to care for patient, and then also just like a case manager, helping patient to set up the appointment with the specialties, follow up with the patient about the medical care. So far we we also planning community events to promoting the prevention of and also early detection for hepatitis B, and then also promoting the vaccination for the hepatitis B.
All right, when she helps us with, we're trying to set up something similar like New York City with the household contacts, trying to get people to tell their family members, like patients who have Hep B, to tell their family members to come get tested. So she's been helping us with that. It helps when there's a personal contact. All right, and Judy's there.
Yes, my name is Judy Yuan, and I'm part of the team. I'm here working with Ruth and Wenqi, and I support the data. So when I get consents back, and I input the data into the database. Yep.
Thank you. All right, and then maybe health department people? Just you, Jill?
I guess so.
Jill's on. Suda's on somewhere. For some reason, she can't be heard.
Oh.
But go ahead.
My name is Jill Denitzlar. I'm the perinatal hepatitis B coordinator for the New Jersey State Department of Health. And usually I have a counterpart, Laura Taylor, who's currently our viral hepatitis coordinator, and she's a health educator. And I guess that's kind of it from our side.
Great. So our first matter of business is just to review and approve the minutes, which Ruth had attached. So if you guys just want to take a look real quick, and if anybody can, if somebody wants to make the motion to approve it. Anybody?
Hi, Sue.
Yeah, oh, there you
Hi.
are.
This is Surya Sharma.
I'm glad you were able to get on.
Yeah, I was trying to, but I didn't realize that, you know, our computer doesn't have a microphone.
Yes, usually most people can't do the computer microphone.
So that's why I have to go through the phone, you know. So now I'm listening through the phone. Yeah, this is Surya Sharma. I'm a public health rep and working on the New Jersey Hep B Coalitions and working with Carolyn Daniel.
Great. And Carolyn's supposed to be on, right, Sudha?
Yeah, she should be. Maybe she's busy in something, but she will be shortly, probably.
Yeah. Okay. All right. We'll look forward to having her on. All right. Anybody want to approve the minutes?
I'll approve them. This is Jill.
Okay. Thank you, Jill.
No problem.
All right. So now I'm going to turn it over to Nirah, and she's got a lot to share with us. So you know, I'm going to leave plenty of time for questions also. So Nirah, take it away. Everybody can see your slides, right?
Yes.
Okay.
Great.
I just want to clarify that I have like 20 minutes or so, right? 20
yeah,
minutes?
I mean, you could actually, let's see, it's 1:16. Yeah, you could. I think we could allocate like 20 to 30 minutes, and then our stuff at the end will be pretty quick.
Okay, no problem. I just want to make sure. Okay. All right. So I'm going to review our up-to-date New York City Health Department hepatitis B information, resources, and activities. So my contact information is on the first slide. Please feel free to reach out to me with any questions at any time. And then our coalition website, hepfree.nyc, is also a central hub of information related to everything I'm going to talk about moving forward. So the first thing I wanted to review was some information from our recently released 2015 Hepatitis B and C Annual Report of Surveillance and Program Activities. Moving along to the next slide. This report is interesting because it was actually required by law by City Council to be submitted for the first time this year, September 2016. There was actually opposition to City Council requiring this and introducing and passing this law, but it is in fact a law. So moving forward, we will be definitely developing and disseminating this report annually. We likely would anyway, but this puts additional pressure on it, and ideally it also raises the visibility of the report amongst elected officials and even health department staff. So the report is very thorough. It includes information about surveillance in New York City. We do have a robust surveillance system in New York City, so acute and chronic hepatitis B and C rates, perinatal hepatitis B rates, and demographic information, which I'll talk a little bit about in a minute, hepatitis C and youth information, and then information on special surveillance or research projects like hepatitis C, Medicaid data review, utilization review, hepatitis B and C deaths in New York City, liver cancer, and viral hepatitis in New York State, which I'll also talk about in a moment. And then our programmatic activities, so some of the direct service programs that I'll talk about also in a moment, but those, in addition to Hep B programs, there's many descriptions of hepatitis C programs and their outcomes, our community organizing activities, and our public health education activities, and then also our goals. So you can download the whole report. I'm going to go through a few highlights that I thought would be interesting to you in the next slides. So just to give a picture of the lay of the land in New York City, we still estimate that there's about 100,000 people with hepatitis B in New York City, and there were 7,719 chronic hepatitis B cases newly reported in 2015, and it's actually the newly reported hepatitis B cases has slightly increased in the last few years. We don't know exactly what to attribute this to at this time, but the hepatitis C cases actually have decreased slightly, so it's a markedly different trend. Fewer than 50 acute cases of hepatitis B were reported in 2015, which is basically how it is year to year. And there's about 4% of people with HIV in New York City that also have hepatitis B. And you'll see on the map the distribution of case reports follows the immigration trends. So there's a high density of immigration population in eastern Queens, Flushing area, and then southern Brooklyn, Borough Park, Sunset Park, and lower Manhattan, Chinatown, some in Staten Island, and then northern Manhattan, Harlem, and the Bronx, there's African immigrant and Vietnamese immigrant populations.
Nirah?
Mm-hmm.
Hi, Carolyn Daniels. How are you? Just want to ask a quick question. So the 50 acute cases reported in 2015, is that down from what was reported in the year prior, or is it about the same? Do you know?
So without looking, and that is something I definitely will look into. I just don't want to do it. I only have one screen available now, so I don't want to do it now. So I think it seems like it's pretty much the same year to year. It may be you know, a few dozen higher or lower, but that's not too much lower than I would expect. So I'll get back to you with the correct information as soon as I close my slide set.
Okay.
And as you know, we just don't get very many cases reported of acute hepatitis B because it's often asymptomatic and very few people are tested during the acute phase. So some interesting elements of this report, and also a recently published article in the Journal of Clinical Infectious Disease, is the New York City Department of Health did a match with the viral hepatitis B and C registries and the New York State Cancer Registry, and to look at the intersection between liver cancer and viral hepatitis. And so of 8,827 people diagnosed with liver cancer between 2001 and 2012, it was interesting to find out that 38.4% had hepatitis C, while 17.9% had hepatitis B, and 2.2% had both B and C, and then the remaining had no viral hepatitis. They had maybe other stressors, fatty liver, etc. So I just thought this was a bit surprising because we often hear more about hepatitis B and liver cancer than hepatitis C, but nevertheless, it's also good to know that how hepatitis B and liver cancer do affect New York City. And so I would expect it to be somewhat similar state to state. I don't know of any other states who've done this analysis, so I thought it might be useful for you to learn about. Another interesting thing, I believe, from the full paper was that people with hepatitis C were diagnosed with liver cancer generally a bit later. And I think that though we have a lot of work to do in the area of hepatitis B and liver cancer screening, it seems like people with hepatitis B are getting screened earlier, finding liver cancer earlier, and therefore morbidity and mortality is a little bit lower.
A lot of times also people with Hep C already have cirrhosis.
Yeah, and
Hep B don't.
And also I think this was not included in the study, but with people with hepatitis C, I think have higher rates of alcohol use and other comorbid conditions that would exacerbate their health condition and increase the chances of liver cancer.
Right.
And so then looking at deaths related to hepatitis B, C, and HIV in New York City, the big news is that the deaths related to hepatitis C have now are equivalent to HIV, but as you see, the deaths related to hepatitis B are significantly lower, which is a good thing, obviously. But it also is, unfortunately, one of the reasons why the disease is like deprioritized as a public health issue, because it's not perceived to be as risky in terms of causing health issues and death, premature death. So again, I'm just showing you because I think this is unique information available in New York that might be of interest. Other interesting information we have to share is some country of birth data from our perinatal hepatitis B program. So in 2015, there were 1,493 hepatitis B positive women who had a live birth in New York City. And as you see, about more than half are from China. There's a significant proportion from Africa, and then the rest of the countries represented the greatest number of additional cases. So this is helpful in terms of understanding where we need to target for outreach and screening of contacts and raising awareness for linkage to care purposes. And you know, our perinatal hepatitis B program has done very well in terms of preventing infection amongst infants. So 99.2% of infants born to positive mothers did receive post-exposure prophylaxis, and at least most of the vaccine series. So there was only one.
Can you hit that hide button, Nirah?
Okay, yeah, I was wondering if you could see that. Yeah, sorry.
Yeah, there you go. Thanks.
Yeah, and 87.7% received the complete vaccine series, which is lower than we would like, but it's still pretty good.
Really good, yeah.
And if you're interested in more detailed data, this slide actually just has a graph as an example with hepatitis C, but we have an online interactive data portal called EpiQuery, in which you can see detailed information about acute hepatitis B and chronic hepatitis B by various different search categories, such as neighborhood, age, I think gender. And so it's just an opportunity to dig a little bit deeper, and I just think for other states it's interesting to see what types of information is available, and if there's anything you can glean from that as it relates to New Jersey, seeing as how we're so close to each other.
Mm-hmm.
Okay, so those were just the highlights that I wanted to share from the annual report. I'm just going to talk a little bit about the Hep B Coalition, does anyone have any questions before I move on? No? Okay, great. So the Hepatitis B Coalition is now part of an overarching sort of like umbrella network that we call Hep Free NYC. And Hep Free NYC is a citywide network organized primarily currently by the NYC Health Department, and it's comprised of both the New York City Hepatitis B Coalition and the New York City Hepatitis C Task Force. Generally, the goal of the network is to build community capacity to prevent, manage, and treat hepatitis B and C in New York City. And so by community, we mean, you know, the whole community, so the health department, government organizations, healthcare providers, health businesses like pharmacies and pharmaceutical companies participate, community organizations, so all sorts like substance abuse treatment programs, ethnic service organizations, and so forth. And really what we try to do with this network is facilitate networking of community stakeholders, identify and share existing viral hepatitis resources, and then identify community needs and ideally develop collaborative strategies to meet those needs. So we meet regularly in person. The Hep B Coalition meets quarterly, and then we have a pretty robust online presence, so we send out many emails a year regarding our meetings, special alerts, a monthly newsletter, and then we have our website, which is a central hub of information, kind of like a clearinghouse of information and resources for our community partners. And then we have an advisory board for each of the coalitions, so one advisory board for the NYC Hep B Coalition. We have a chair for the Hep B Coalition, who is James Park, a hepatologist from NYU currently, and then committees. And currently our committees, make sure I don't have it there, currently our committees for hepatitis B are Team HBV NYC, so a student initiative, and a local chapter of the Coalition Against Hepatitis in People of African Origin, or CHIPO initiative. And then we have like a communications committee and awareness day committee that pertain to both B and C and are comprised of people from both groups. I should certainly note that the NYC Hepatitis B Coalition was founded in 2009. Sue Wang was definitely one of the founders. And since then, we've been meeting quarterly and I think pretty stable resource in the community for bringing people together and working on hepatitis B related issues.
I don't know if you're going to talk about, but we'd love to hear like what you think, you know, maybe not now, I guess when you get a chance, of like how you think you guys really got it up to that point where it's stable and getting people engaged, because that's kind of what our challenges are.
Okay, sure. So I don't have that on the slide, so what I'm going to do is just verbally tell you now.
Okay.
So basically, I think there were fits and starts, and again, Sue is there, so she can testify to that. In the beginning, you know, there was a really large group that was convened, and I think it was fairly high profile. It was originally convened by a preventive medicine resident who was in the health department for a short period of time, and I think really successful in bringing community stakeholders together, but the follow-up plan might not have been in place maybe the way it should have been, or might have even been overly ambitious to begin with. So we kind of, I feel like, had like two phases of startup, so like the initial idealistic phase and then the realistic phase. So we're lucky in New York because we have a dense and area and a small, relatively small geography. So with the Hep B Coalition, we are able to have a citywide meeting. It's quarterly, so it's not, you know, too much travel time for participants to do 4 times a year. People do travel from all over the city to our central location in Manhattan, but it is only at maximum, I would say, an hour-and-a-half trip, which is really important factor. And then, so what we've always tried to do since we kind of followed really the successful model of the Hepatitis C Task Force. So at every meeting, we have everybody introduce themselves, share a little bit about where they work and what they do with hepatitis B. It's an opportunity for them to share an update on their program, any resource that they want the group to know about, any upcoming event or recruitment opportunity that they may have. So trying to ensure that every person has a voice at the meeting, has an opportunity to share what their thoughts are. And then we have usually presentations from the group on special programs that they have been working on, and it's meant to be an informal environment, so an opportunity to present work in progress or work that may not be the type of work that's presented at a conference, for instance, so, you know, a program activity or a new resource or something that they want feedback on. We usually have a series of like 4 short presentations, and then we try to update the group on any committees that are ongoing, to increase involvement in those committees.
How long are your meetings again? I remember they were like definitely more than an hour, right?
2 hours because they're in person. Yeah.
Right.
Yeah. And then, you know, ideally, how many what?
What are the actual committees that you have?
We've had different ones in the past. I'm afraid to like click away from the slides because can I get back? Yeah, I'll be able to get back to my screen. Let me just show you what committees we have now. So if you go to the Hep Free NYC website, hopefully it will go quickly. Yes. So if you go under Hep B Coalition and then committees, I'm sorry, my system is a little slow right now.
Of course. This happens to me too whenever I'm on a call. Whatever you need will pull up. Yeah, that's really, the website looks really good. I remember we used to have it like it was like a Google website. Did it look as nice as this?
Yeah, it started as a Google website. Yeah. So all the B and C committees are currently on the same page. So we have our advisory board, Team HBV NYC is like a Hep B focused committee. The LGBT committee pertains to B and C, faith-based B and C, but it's just right now a little more focused on C. CHIPO is more B focused, and then our awareness day and planning committees and communications committees are both B and C. And you know, maintaining the committees is challenging. I now have a staff member, Daniel Calder, who is the primary person in charge of sustaining and building the capacity of our committees. And so that's what's happening now. And then the other thing that we always do is disseminate our meeting highlights. So the meeting highlights are an opportunity, and I'll just click on one of them, to share the information that, oh no, it's not actually bringing you to the full meeting highlights in this particular one, but let me show you a past one. I think this is an important tool as well because it gives an opportunity to showcase the coalition partners. It's almost like an advertising tool. It's like, so you can see what was discussed in the meeting, the slides associated with it, so it reaches a wider group than was actually there in person. And then at the bottom, we always include who was there and their contact information. So that's helpful because then it helps put people on the map, I guess you could say. It gives them credit for their attendance.
We had 33 people at that meeting. That's so impressive.
Yeah, these days we have probably an average of 35, 40 usually, yeah, at every meeting. So, yeah, and that's publicly available. So, okay, and so then in terms of what the committee has thought about the coalition, so in 2014 we did a formal evaluation, and honestly I've done it several times and it doesn't really change too much over time. But basically, the coalition and task force members feel that these opportunities to meet in person help to identify community needs and then respond to community needs. So we really make a strong effort that if something is expressed as a problem during the meetings or even between meetings, we do our best to address that, like ensure it's documented in the meeting notes, ensure that there's some response to that need expressed, like if it's for a material, try to really work on a strategy to develop that material. If it's for funding or something, try to increase our dissemination of funding opportunities. And then they also find it a good networking opportunity, so like an opportunity to just meet with other organizations and collaborate on events and projects, like screening events, for instance. And then in that same evaluation, we asked about priorities for 2015. And again, in my experience, this doesn't change too much over time. So always, increased public awareness is seen to be important. Increasing funding, always top of the list. There's still a strong need to increase medical provider awareness, to participate in awareness events. We specifically asked about participating in awareness events because those are very labor intensive and it's not always clear what the outcome is of them, but the members felt that they're good generally for like building team spirit, raising public awareness, raising awareness of elected officials and government officials, and then they perceive, which is ongoing, increasing just the hepatitis knowledge and skills of members. So the coalition members are experts in the field and working on health policy issues. And so how we've responded to that is in terms of increasing public awareness. These days we do a World Hepatitis Day press release from the coalition itself. In the case of Hep C, we have been working on an awareness campaign for hepatitis C at the health department. Unfortunately, not yet for B, but that could change. We have our funding board where we list every single funding opportunity that could help our partners support their work. I'll talk about the City Council Viral Hepatitis Initiative in a minute. That's probably our #1 advocacy and activity that we work on these days. We have a lot more going on in the case of clinical provider capacity building. In the case of hepatitis C, we're working with 2 different clinical networks to improve their hepatitis C care. That could be ultimately leveraged for hepatitis B. We commemorate at least these 4 awareness days every year as a group. And then generally our meetings, monthly newsletters, and trainings, we disseminate increased knowledge and skills of members. And then we just do our best to disseminate all action alerts related to hepatitis policy, and then participate in New York City and New York State legislative awareness days, ensure our coalition partners are aware of those days and are empowered to participate. So this was our event on the steps of City Hall on National Hepatitis Testing Day. I think we had the most people there ever, maybe 125. Oh, yeah. And it's B and C together, so that's important because the numbers are just not big enough in any one side. So there was about 125 people there, and people really came out with their signs, and it really helped a lot. And then a few of us, many people you may know, both B and C, but in Washington, D.C. at Hepatitis on the Hill last year, which I think was also very important. We did a lot of social media around that as well. And so next I'm going to just cover our City Council initiative, specifically the Check Hep B program. So in 2014, members of the Hepatitis B Coalition scheduled a briefing with 3 City Council members who then became the champions of a viral hepatitis initiative. So the majority of the programs that were later funded were present in that first briefing. And what happened in that briefing is each program, so Charles B. Wang was one of them, presented on the burden of hepatitis B in their center and the need, what they needed. And most of them said they needed support for uninsured as well as support for clinical support, so linkage to care, care coordination, services. And so then later that year there was a hearing at City Council for both hepatitis B and C, at which many community partners testified. And the New York City Council then established the Viral Hepatitis Initiative, which funds 3 direct service programs, Check Hep B, Check Hep C, and then a Hep C peer navigation program at syringe exchange programs. It also funds another initiative called the Empire Liver Foundation, which is a network of New York City hepatologists to do clinical capacity building, but they're currently focusing primarily on hepatitis C. So one of the tools we used to communicate the urgency of need with City Council was doing these kind of quick and dirty City Council district maps overlaying our hepatitis C case report map, hepatitis B case report map, so we can say specifically Council Member Menchaca, District 38 has the greatest burden of hepatitis B in your community, and then you can go further and explain what that means for that district and then what is needed for that district. So if anyone's interested in doing this, please let me know. I can provide technical assistance, and it was a very simple kind of way of doing it.
Oh my God, that is amazing.
Isn't that nice?
Yeah. I mean,
I don't know if we have our data that
politicians behind us that you could show them this. That is really powerful.
It was probably the most
powerful. Did it
powerful.
turn out, were the top 3 the ones that support you the most, do you feel like?
Yes. Well, no, not ironic. There is a Check Hep B program in Menchaca's district, but Chin and Ku are the 2 Hep B champions, and then there's one more, Corey Johnson, who's the health committee chair, who's in the Chelsea area more so, but you know, he's the health committee chair, so he deals with the whole city. But Menchaca, interestingly, but there is one Check Hep B program in District 38. Everyone has their own level of urgency about it. So then moving on to the next slide, this is where the Check Hep B programs are currently funded. So those in the orange and white polka dot are newly funded this year. The others have been funded from the beginning. Actually, 5, Brooklyn Chinese Family Medical Center was funded for the first time in FY 2016. So it has increased every year. So again, it was the district maps was a great tool to share with the council members where the program was needed.
This is so great. Is Jill still on the call? Are you still there, Jill?
I am here.
Hi, so this is Carolyn. I'm just wondering, do we have that kind of information by county where we can actually target people who are positive for HBV, where they reside and what county, that we could put something together like this with Nirah's assistance?
So I mean, we definitely can look at like how many positive individuals, like, you know, people we have by county, for sure, and we can look at the you know, density of cases that we have in that manner. Sure, like the data's there.
Maybe we should think about doing that. I don't know if you guys are doing that with your FOA that you're working on or not, or if it's just programs, but I think to actually see the residents, to see where people reside, and to share that with our elected officials could maybe generate some movement for us. So we can think about it.
Yeah, we could definitely like have a side chat about it for sure. You know, sometimes people get a little bit weird about sharing data and how we share our data here.
Yeah,
so you know, as much as I would always love to do it, I can't promise anything, but we could definitely talk about it.
Yeah, we're not talking about any PII or anything like
that. No, absolutely.
Okay.
Yeah.
Okay. Great.
I mean, did you have any issues with people when you did that, Nirah? Did anybody give you any difficulty with that?
No, and I just want to stress that the way we did this was like we basically overlaid 2 different maps, so we didn't do any additional, we might have done a little additional analysis to get the number in the district actually, and I have to inquire with our surveillance department how that happened, but the map itself was done by like overlaying 2 maps, so it wasn't hard to do. So I can share that with you, but no, we didn't get any resistance, and it was very helpful for the council members for sure.
Yeah, I always like to. Go ahead. I'm so sorry.
Oh, no,
it's just yeah, I always like to pepper the my like enthusiasm, because sometimes like silly reasons are roadblocks for us here. I don't know why. So
yeah, I'm saying maybe if like there's some you know, if New York City was able, like it came from the health department, then
sure,
that might help your case.
Yeah, no, we also experienced the same thing, so I totally understand what you mean. This one didn't happen to be a problem, but we have many others. Okay, so then I'm trying to go quickly because I know that you have a few things you wanted to discuss after. So just in brief, I'm going to just tell you about the Check Hep B program. So it's at various different types of organizations, including community-based organizations, public hospitals, and health centers. And I'm just going to, just for full disclosure, so each program was initially funded by City Council $43,000. And then it was increased by a New York State match to $64,000 total for the year, which enabled them to employ one hepatitis B patient navigator. And what the health department does is, contract management. We developed the program protocol, which I'll be sharing with you, the materials and resources, and then we monitor the program and report on the program. And what the programs do is outreach and enrollment. In this case, we, in our model, we have the patient navigator only enroll hepatitis B positive patients. So we don't start at the point of outreach and screening. We start once they're identified as positive, because in New York, there was a need for that. Like, there was a lot of screening going on, but less linkage to care. So we really needed the linkage to care component and care coordination to support complete medical evaluation. And then the navigator does an assessment of barriers and referrals to overcome barriers. Linkage to Hep B medical care is primary goal, and then provides these care coordination services, which are pretty standard, but we have like materials for how the navigator conducts each of these activities. So we have a whole package of materials, including a protocol. We have a workflow diagram as well, which I could share with you. We have a patient navigation form that they use as a primary documentation tool, which includes demographic information, the assessment information and referrals, clinical care tracking as it relates to the patient navigation work. So it's not used by the clinical provider, it's used by the patient navigator to ensure that the patient is moving along the continuum of care, and discharge information, and a care coordination log, which is like case note template. And then a database, which is an exact referral reflection of the patient navigation form. And then we have a health promotion guide, which is basically like a training for the navigators in how to deliver health education and motivation. And then a form, 2 forms for the patients and the navigators to use together, the care plan form and the treatment planning form. And I'm going to show you examples of that in a minute. So here's what the patient navigation form looks like. It's 2 sides, and this is all of the information that the patient navigator tracks over the entire time the patient is in the program, and then enters into the database. This is a screenshot of what the database looks like. It's very, very straightforward and user-friendly, and again, it's an exact reflection of the form, and then that's submitted to us monthly for monitoring the program. This is the health promotion guide and topics. So Hep C basics, getting ready for Hep B care, like overcoming barriers, getting ready for treatment if treatment is recommended, and then generally staying healthy with hepatitis B, which also pertains to contact notification and screening and vaccination. We have a care plan that's used by the navigator and the patient to plan what they're going to work on together. As in terms of patient navigation activities, it doesn't replace the clinical care plan, it complements it. A treatment planning form, so if the patient is recommended treatment, it's an opportunity for the patient navigator and the clinical provider to work together to ensure they understand their regimen, any treatment disruptions they may have, to plan ahead for those. So in terms of the program, the patient navigators are generally college, have finished college, or in some cases in college, finished a bachelor's degree. They have varying years of experience with Hep B and navigation services. One key characteristic of the Hep B patient navigators is they speak usually multiple languages, so all are bilingual, and some speak multiple languages, up to 7 in the case of one of our African navigators. Each has a supervisor that helps with reviewing their work, providing support, and is a secondary contact for us. And then we provide training, and then there's ongoing trainings available through our coalition. So in terms of outcomes, up until June 30th, 2016, we've enrolled 402 patients, 389 completed their first medical appointment, 369 completed their medical evaluation, which was our key goal, and then the majority of those who were treatment candidates did start treatment. Many were uninsured, so the navigator helped get the medication through the patient assistance program. And in the interest of time, I'm not going to go through the details of the patient characteristics. I just wanted to share these with you to let you know that it's like a very diverse patient population born in many endemic countries and generally has been successful in reaching vulnerable patients in need. So when it says uninsured here, it usually does mean uninsured, undocumented. So it's very, very helpful to have this resource to help gain trust in the healthcare system and get through Hep B medical evaluation and on treatment if needed. So in terms of next steps, we're just, we've worked really hard on developing these models and programs and happy to share them. So we do want to definitely sustain the existing Check Hep B program in New York, but also happy to share with other areas. So Hawaii Department of Health is actually implementing the Check Hep B model in some of their community health centers starting this month. So I'm excited about that, and we're happy to share any others. And then we also have another project that's starting at the health department where we're going to be doing outreach to the mothers who are part of the perinatal hepatitis B program who may not be in care for their own health related to hepatitis B, and ensure that they are linked to care, because up until now the primary focus has been on ensuring the infant does not go on to have chronic infections. So we're going to be employing 2 Hep B telenavigators to do linkage to care and retention and care support for the mothers. And so I thought that might be of interest to you moving forward as well. And yeah, that's really great. It.
Super. Oh my, yeah, that's amazing, me applauding. Right? That is great, Nirah. Oh my goodness.
Yeah, I feel like this is so amazing to see after, because I left in 2013, and just in 3 years, you guys have really, really, this program is really robust. And
I mean, Sue, that's when we met each other, and I'm like, I can think back to, I was so impressed with the program then at the Wang Center, but this is like 100% over and above and beyond that. Very, very, very good, Nirah. So much work you guys have accomplished, really.
Well, thank you. And I mean, I think there was a lot of people that were instrumental in making that happen. It was a huge team effort. I do think also like the greater attention to hepatitis C due to, the media, the pharmaceutical funding that went into that did have at least some helpful benefit to the hepatitis B work, and like raising the visibility, and still is not quite the same, but I do think that helped a lot because there was more like funding allocated to these programs. So
wow.
Yeah.
So but the funding for Check Hep B and Check Hep C, does that come all together from City Council, or are they 2 very separate grants?
It does. Well, it comes all together, but these organizations are named for either B or C, or in one case, or in 2 cases, it's both. So 2 of the centers have both programs, but usually it's specified, like this is funded for Hep B and this is funded for Hep C.
Okay.
Yeah.
I'm gonna say like, just so we can get everything done. I know people have questions for Nirah. If you guys are okay extending just for like 10 minutes, we'll probably do that. Otherwise, if you have to go, feel free to go. But those of us who can stay, maybe we can finish so we can get questions to Nirah, and then just finish our last couple pieces after that. Any other questions? Wenchi, Ruth, Jill?
Not so much question. I'm just in awe. That's all. I've got some ideas and thinking.
Great. Well, I mean, honestly, we're happy to help in any way we can and share resources. So just feel free to reach out if there's anything we can do.
How do you, when the patients are, because I see that the navigators are within each organization, and not all the organizations have actual physicians seeing the patients. So my question is, where do they send the patients, especially the ones that are undocumented? And then is there any issue with the data sharing? Like, do they have to sign a consent, or is it just, is it not a big deal because it's considered surveillance and the DOH can do surveillance?
Okay, so the community-based organizations, it's kind of different for each one that do not have clinical care on site as to what they do. So just very specifically, like African Services Committee previously was referring to Bellevue Public Hospital, but then there are some obstacles recently there because they have really long wait times, and so patients were lost to follow-up just in that long period of time. So now they're trying to find other community health centers to develop. It's really important to develop an MOU or a linkage agreement between a community organization and a hospital or health center to formalize the, the referral processes and ensure there's full agreement to take the patients. Luckily in New York there are quite a few organizations that do work with undocumented. I know that's not the case everywhere, especially undocumented who have hepatitis B, and hepatitis B care and treatment I think is still unfortunately perceived as optional in some cases, like it's not emergency care usually. So that's an issue. And then Korean Community Services, for instance, has identified a health provider who does pro bono work with a certain number of patients per year. So they worked out an agreement about that, and I would recommend speaking directly to Sarah Sun-Suk Kim, who is their program manager, about how she worked that out, because that's very unique and it's been very important for their program. And then the others refer to an FQHC for sliding scale fee, and that can be challenging for some patients because they just won't pay out of pocket. So there still are barriers there. And then as far as data sharing, sites sending us data, H&H at the public hospitals now are refusing to do that. So that's one outcome that's recently come. But the others do send it. There's a consent that we offer for the program, and we have a data sharing agreement, keep everything confidential, and it's used for training and technical assistance and monitoring purposes. So we haven't had a problem with anyone other than H&H Public Hospital.
Is it possible to share the patient navigator form?
Yes, yes, definitely. Yes.
Yeah, very nice form that you guys made. Very comprehensive.
Yeah, I mean, it's been now tested over 3 years, so that's why I'm excited to share it, because I think it is pretty comprehensive now and streamlined. It doesn't include anything that's not necessary, I don't think, and so.
Yeah, we do have, in our center, we do have the problem just facing a lot of undocumented patients that couldn't be treated, even though we can screen them, but they cannot be treated because they are undocumented, and then they couldn't get any health benefits in the country. So most of the time we have to, really bad, but most of the time we have to refer them back to New York City because they have a better health center over there, provide multiple language support. Yeah, if we can figure out, have something center in New Jersey like that, maybe we can just improve a little bit, link to care. Like you say, if you wait a little bit longer, the people always just drop off. So if we can have closer service and then have a better patient navigator to link both of them, I think we can just successfully to follow up with these patients in New Jersey.
Yeah, it's incredibly challenging to deal with the uninsured situation, even here, but here we just have more public hospitals who do sliding scale fees. I actually do have to go. I realize I have another call that I have to be on in a minute, but I do want to also mention that in New York there's a program for Hep C, HepCap, which provides free hepatitis C medical evaluation and support for care and treatment for Hep C patients only, but I think something similar should be for Hep B as well, but that's obviously another huge advocacy issue. So. Hello?
Yeah, we're here.
Okay, sorry. You know what? I realize I have another call that I have to go to.
Why don't you go ahead, Nirah? Thank you. It's been so good.
I'm happy to answer any additional questions offline, so please feel free to reach out.
Thank you for getting her to do this. This is great. It's really been so informative. Thank you.
Thank you. Okay, bye-bye.
Bye.
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 What a great idea, Sue. This program is so amazing, just like you said, in the 3 years. Oh, my goodness, they've done so much.
Hello, Dr. Wong.
We may have lost her.
No, we can kind of hear her talking through the wall, but I don't know if she's, oh, here I think she's, wait, she's,
Maybe she hung up on the
I think she unmute herself. Are you unmute yourself? I can hear she's talking over that wall, right? She's like, we just don't know what she's talking about.
Can you ping her?
Can you just come over, Dr. Wong?
Yeah.
I've been talking this whole time. I don't know what the deal is.
Yeah,
I guess
were you on mute?
No, I tried. I actually unmuted and muted myself twice, and my phone is just, I don't know, it doesn't like me anymore. Yeah, I was like, blah, 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 and then I realized nobody could hear me. I was like, why is everybody interrupting me? Why is everybody talking right over me? Oh, talking about technical issues.
That was really good, Sue. Thank you.
I know, isn't she amazing?
Yes.
Yeah, she's well, and it's just, I mean, and you know, really, I mean, Nirah doesn't give herself enough credit, but she really goes above and beyond. I mean, she was the one when there was no money, she was just putting in all this time and energy herself. Like, she puts together these really long emails that list all these resources. You can tell she's very organized, and like whenever she presents something, it's visually like really easy to read, and you know, all the she's very detail oriented. And I think that she put in so much effort that people realized, hey, we should do something more, and she was really good at getting people together. And obviously, like DOH can't lobby, but she was able to get, I think, all the other organizations to do the advocacy. And they had like a legislative day, and that's something we could even consider, where they hosted like a lunch with all the council people when they were in session, and then they would bring patients and people to kind of talk about Hep B. Just to educate them, you know, about the disease. And it's amazing. Even the council people, there's a lot of misinformation. And then like there was even the Asian council people thought that, you know, you could get Hep B from eating and sharing food with people. So
it's amazing to me. I mean, it was so informative and so well put together. She stimulated a lot of ideas also. You still there, Sue?
Yeah.
Okay.
I was trying to put her on speaker, so because I got on the phone, so now when she can't hear.
Okay, so I was saying that she really did stimulate a lot of ideas for me. Anyway, I'm thinking, you know, maybe there's some things we need to do. We know we need to do some things differently, but she's given us some clear paths, I think, to that. I'm wondering if, because what we're doing, it just focuses on B, maybe we should expand the focus to include B and C. Something else that occurred to me was, you know, we initially tried, and we had people from Bergen County Health Department that used to come to those early meetings when we were meeting, and then they kind of, you know, fell off the radar. But I'm wondering even if we got one or two of the local health departments in the counties where we have the denser population, Asian American populations, to work with us and maybe kind of help to champion this, that maybe we could get a little bit more traction than we have right now. So, you know, I was thinking about that. Maybe do we need to reach back out and try to recruit those health departments? Certainly Bergen County would be one that we would want to go after, I would think, in that northern area, maybe Essex, because of the African American, Black African populations that are there. She also mentioned having hepatologists in their network. Maybe that's something we could look into. I mean, there's so many things we could do differently, but I think realistically, maybe we could tackle some of the easier things that would help us to expand and get more of a focus. So at some point we could become and have a really robust program the way that they do in New York. It's an amazing program.
When you mentioned Bergen County, did you meet with them in person?
Yeah, we met, so back in 2013, we had, I would say, at least 3 face-to-face meetings. That first one that we had was actually at Monmouth Hospital, and so we probably had about 20 people that showed up for that meeting, and 2 of them were folks from Bergen County Health Department. The health officer, Michael, I forget his last name, he's not there anymore, he retired. And we had a nurse, a couple of nurses from the health departments, those local health departments that attended. And then they just stopped coming. You know, we continued to have the meetings and would send out information, but they, for whatever reason, just didn't, you know, engage.
Well, you know, that's something that I was thinking about when Nirah was talking was she mentioned the in-face meeting, and she said they will travel an hour.
But New York, if you come from if you come from Queens, but you can, stay island. Different from driving. Yeah. An hour only, yeah. And you know what they would do, which is nice? They would actually, different partners would host it. So like American Cancer Society was a very common place. So that's in right by Penn Station. Okay. So it's very easy for people to get in from Island, and it's kind of a midpoint. They find it local. They find it central. I feel like ACS was one of the most common places. I don't know where else. I think at some point they did it in Flushing. At CBW, but
and I know that we have a challenge because of our geography statewide.
But I wonder we talked about that during last coalition meeting. So that's why we have that in the Central Jersey, so people easy to travel with. And then we also talk about that face-to-face is difficult for us. It's because we are state, we are not city.
Right.
So it's kind of like state has a different kind of structure for the city.
But it's definitely an idea because they don't meet every other month. It's like quarterly.
Right.
Yeah.
Yeah. So if you can plan ahead and plan, you know, make it bigger, you know, more of these like really good talks that people want to go to. But I do agree that something about the face-to-face networking, will get something out of it, you know, besides just information. They meet people, and like I like how she was saying that it's a great way for them to be seen also, right? Because sometimes there would be, I feel like they've had industry there. They've had the Touro College of Pharmacy was always there for some reason. And so they get their name listed. It's like more visible. So you're trying to appeal to that also, that face.
You know, if we think about if our meetings are quarterly and we think of who can, you know, kind of like rotate and go different regions in a quarter it's only quarterly, and we identify maybe who is a partner in a particular region.
Maybe they could host it.
They could host it. They might have more local networks.
That's true.
To like invite people in. Yeah, and then if we think of something that's going to be personally vested for them, then maybe we might get more of a local attraction as we travel around. I mean, we could be the Coalition Roadshow for 2017.
Yeah, but I think the hook has to be, you know, what is going to get those folks regionally to come out. And I think people do like face-to-face meetings, but you still need a hook. And so I'm kind of stuck on this whole thing with data, and that if we can get the data to show what that HBC, HB, HBV, HCV, what it looks like regionally by county, that may be a draw to have people come out to these meetings. So I don't know how successful we can be in doing something like that, but we need to hook to make it relevant to them, to say this is really a problem, a concern in your city, in your locale, in your municipality that you should be addressing. And here we can support you. We have these resources. We know how to do this. It has to be structured to draw people in, and right now it's not. So I think that's a big part of it.
Yeah, I think that maybe, I mean, there is some data. Obviously, we don't have data to the extent that New York City does.
Right.
If we can have, I mean, what we could do now, I'm thinking, well, maybe this is what we should do. Maybe we should do these. Question is what? Because she can hear everything on the other side of the wall. Sorry, we're probably being too loud.
So anyway, I feel like we can just identify some of the cities first. We don't need like whole like New York City. They have like whole every district, but we can just say from us, we can just say
identify some of the city, and then for more city, I have more immigrant or more like Hep B case. If we can just identify this city and then use this city as a model and then start with the coalition, that would, I think, the quarterly meeting, that would be easier than just like waiting for the data to show that how many Hep B in every single